Good morning, dear Barry, dear faculty members, fellow faculty members, and of course, dear colleagues. Let me begin with apologizing for not being with you live this time. I faced a terrible dilemma of either visiting my son in the United States after 1.5 years and seeing my grandchildren or being with you today. I decided actually to go to the States. It is a pleasure to update you to this topic, the new anticoagulants. I've been talking about this a few times already, but this time I promise you, we're really around the corner. So I'll give my presentation. I hope that my dear friend and colleague AJ Kicker will be able to answer the questions. Otherwise, I'm more than happy to do that afterwards. Let me also start with thanking Sanofi for making this symposium possible again. So without any further ado, my task is actually to try to convince you that we can separate hemostasis from thrombosis. And the potential of factor 11 as a target for this uncoupling is really growing by the day. This is a slide that I borrowed from Jeff White's and basically summarizes the three elements we have in the past. One is the human genetics, as you can see. We do have individuals severe factor 11 deficiency, and as you probably know, that occurs in 1 in 450 Ashkenazi Jews. But these patients with their congenital deficiency have a reduced risk of thrombosis with little or no risk of bleeding. Now, the epidemiology, in the sense that factor 11 levels are associated with twofold higher risk of thrombosis, and also the other side of the coin is when you have lower levels, there is a reduced risk. And finally, animal studies. However, the proof, of course, will come from the human studies, and that's what I'm going to share with you. Now, again, this is a slide from a beautiful review in 2017, and I'll show you the updated one in 2021. But this is an important slide to realize that we have different strategies to lower factor 11. So one is the oldest one is the antisense oligonucleotide that reduces the synthesis of factor 11 in the liver. Then we have aptamers, then we have antibodies and small molecules. But the lesson to learn here is not all factor 11 inhibitors will act similarly. And we already have evidence that there are differences between antibodies. And here is an overview from that 21 review by Jeff and his colleagues. And basically what you see on the top here is the different compounds, the abelacimab, the ocizumab, the factor 11 LICA, and the other two, the small molecules. What I'd like to draw your attention is not only that they are different agents, but they also can be given either sub-Q or IV or oral. The onset of action with the factor 11 antisense is slow because you have to stop the synthesis while the others are rapid. And so here you see a few, I would say, classical pharmacological characteristics, but that is really important to understand the difference between the ones. The one I will focus on is this abelacimab because that is the most recent one, and I think a very interesting one. It's a monoclonal antibody that inhibits both the inactive and the active form. So what it basically does, it keeps factor 11 in its zymogen conformation. So it will inhibit when it gets activated by whatever means, but also it will inhibit the zymogen. And here you see a beautiful picture that illustrates that mechanism here. And clearly, the whole compound here is to see whether the factor 11 inhibition is actually translated into a clinical benefit. Now, that was, I have trouble showing you this, but this is the paper with the different authors. This is the classical design of a knee study. And let me take you through this. These are as you can see, 4 different groups. Abelacimab in 150 IV. This was given, and that's important, post-operatively as a single intravenous injection, either 150, 75, or 30, and the comparator classically in these type of studies is enoxaparin. And then there was an venogram at day 10 plus or minus 2. Also classical in this setting is actually the primary efficacy outcome, which is either symptomatic VTE or asymptomatic VTE seen on venography. And safety is bleeding, of course. Now here on the left, you see a baseline, the 3 different doses of abelacimab with the factor 11 coagulation activity, which as you can see is comparable and around 110%. At day 3, so this is 2 days after the intravenous injection, in all 3 groups, you will have no detectable factor 11 or very low. On day 10, as you can appreciate, the lower dose, the 30 milligram, already starts to have measurable concentrations, while at day 30, the last part of this figure, you can see that the 2 lower doses are back to normal, while the 150 in red here still has a decreased coagulation activity. Now, how does this translate into venous thromboembolism? And this is, I think, an impressive finding that we published in the New England Journal just a couple of months ago. And as you can see, if we start on the right with enoxaparin at day 10 on a venogram, about 22% of these patients actually have detectable thrombosis, both proximal and distal. With the 30 milligram, it's 13%, which did not reach statistical significance. But I think the message is that with the 75 and the 150, you see levels of thrombosis of 4 or 5%, which are in this setting extremely low, never seen with any of the DOACs. In actual fact, with the antisense, the highest dose gave a 4% venous thrombosis rate, very, very comparable to what you see here with the single intravenous injection post-operatively. If we then look at bleeding, and here again, we'll go from the lowest dose to the highest dose, and let's start with the enoxaparin. No major or clinically relevant non-major bleeding all the way up to day 30, none in the highest dose, 150, and 2 and 2 in the lowest dose. Now, I think the message here is that the risk of bleeding, particularly in the higher dose, really being absent. If you look at the lower part of the receipt of blood transfusion, really no difference at all. So again, a proof that you can reduce the risk of thrombosis quite dramatically, while at the same time have no bleeding complication. And this is in a setting of knee surgery, and the surgeons in the audience will know that this is an operation that in the presence of anticoagulants, if you do this with heparin or if you do this with warfarin on board, it becomes quite blood-like. What I think is the future, and that's what I said in the beginning, we've been talking about this topic of factor 11 inhibition for a long time. But what you see here is the studies that are planned or about to start with abelacimab. One is in atrial fibrillation, 1,200 patients comparing to rivaroxaban. But I think to this audience, the atrial fibrillation really, I think, will tell us in 1,200 patients, and is going to be followed by a much larger study, whether factor 11 has a role in the prevention of stroke in AF patients. But also interesting on this slide, as you can see, there are 2 studies in cancer-associated thrombosis. These studies will start in November, so this month, in the United States and Canada. One will compare the antibody against apixaban, and the other one in the study against dalteparin, and that's in patients with gastrointestinal high-risk bleeding cancer patients. Again, these studies are about to start, and so me talking about this as really something around the corner is now finally true. Let me just conclude. The concept of the factor 11 inhibition in thrombogenesis is further supported by this study with our colleagues published in the New England Journal. Impressive low rates of VT after knee surgery, no evidence for enhanced risk of bleeding. Post-operative start, which I cannot emphasize enough. This is an intravenous injection given in the hours after operation, and you do see the effect at day 10 very, very clearly. Very different from the antisense, which had to be started 5 weeks before the surgery. Abelacimab is available both IV and subQ and has a bright future. There is no necessity for liver or renal problems to adjust the dose. But of course, the final proof will come from the AF and the CAT studies, because that will tell us whether this drug really is avoided from a bleeding risk and is a great antithrombotic agent. With that, I'd like to thank your attention. And again, my appreciation for Sanofi making this meeting possible. Thanks, colleagues. Thanks, Barry. Have a lovely, lovely symposium. And again, I'm very sorry not to be with you.
As always, clear and to the point. And of course, presenting us with a very exciting, novel approach, now increasingly validated, of factor 11 inhibition with regard to the anticoagulant armamentarium. And as we heard from Harry, convincing data in a tried and tested model of antithrombotic efficacy, the patients undergoing elective total knee arthroplasty, and an ongoing program with abelacimab, but also other inhibitors, but with abelacimab, a large phase 2 study in AF patients, and then 2 phase 3 studies in cancer-associated thrombosis for a general population against apixaban, and for high risk of bleeding against low molecular weight heparin. Now, I see Sylvia has a question, so let's start off with Sylvia, or a comment.
Thank you, AJ. Indeed, it is a comment. So I would like to echo what you already said. It's absolutely fascinating to see and to learn about the dissociation between VTE prevention and not increase of major bleeding. There was a challenging correspondence about 3 days ago in New England Journal of Medicine about this knee study, and the dosing of the control group was challenged. This study used, as we always used in the European and worldwide, except US, the dose of 40 milligrams once per day of enoxaparin. And the challenge was, or the question was, why not the 30 milligrams of enoxaparin twice per day was used? But this is only used in US and not worldwide. So I think this correspondence from 2 people has no negative impact on the beautiful results of this study, which were elegantly presented by Harry. So this is absolutely new era of development of antithrombotic therapies in the future, and the dissociation has been reconfirmed now by this study.
I think that's a very, very good observation. And if we look over the last 20, 25 years of the pathway for the development of a novel anticoagulant, very frequently we start in the phase 2 setting to try and establish a sense of dose ranging with the knee model. So I think there's often confusion about the utility of elective knee arthroplasty as a model to assess antithrombotic therapy with a consistent objective screening of entire thrombosis burden using venography versus development of an anticoagulant for clinical use in the prevention of postoperative venous thromboembolism in knee patients, which is really the preserve of a phase 3 study. And more consistently in that period of time, using the knee study as a model, enoxaparin in a dose of 40 milligrams perioperatively has been the chosen comparator, rather than enoxaparin 30 milligrams BD commenced 12 to 24 hours after operation.
Absolutely.
I think the key of maintaining the methodology, that particular approach, allows us to look across different development pathways for different anticoagulants and try and understand whether what we're seeing is an advance over what we've seen before, consistent with what we've seen before, or adding no value whatsoever. And that's why I feel the methodology used in this study is entirely satisfactory.
Yeah, absolutely. I can't agree more. And I still think that enoxaparin 40 milligrams in this setting of perioperative administration, 40 milligrams is still standard of care worldwide.
Absolutely.
Except US.
Yeah, except US. But if you think about the tens, if not hundreds of millions of patients who have received the 40 milligram dose of enoxaparin,
yeah.
I think it's very difficult to argue, and we did have this debate 15 plus years ago in the low molecular heparin field, of whether once daily or twice daily was the answer to prophylaxis. And quite frankly, both strategies seem to deliver identical or practically identical efficacy and safety.